I will talk today about pharmacotherapy for type 1 MI non-STEMI. I will talk about antiplatelets, anticoagulants, and other therapies, and those apply to type 1 MI, not type 2 MI, and certainly not non-MI myocardial injury, where you have to strictly individualize. Some of those patients, especially in type 2 MI, may qualify for some of those therapies, but you have to individualize. They mainly apply to type 1 MI. They apply to non-STEMI, but also STEMI and post-STEMI care. And I have given about 3 years ago a talk about antiplatelet therapies, which is still appropriate, and I strongly suggest you review it. I won't go over all the details discussed in that talk. I want to start by talking about those other therapies. You really need to understand the nuances of those therapies and not apply them to everybody every time. So, regarding beta blocker therapy, you have to understand the 3 potential benefits of beta blocker therapy: acutely, long terms in MI patients with low EF, and long term in MI patients with normal EF. And I'll discuss those 3. I will give in that talk, in general, a lot of summarized but dense information about all those therapies. I suggest you review those carefully. Those are essential therapies for any cardiologist. I will also throw a lot of trial names. You need to know those, I think, as a clinical cardiologist. So for acute beta blocker therapy, this is the landmark trial you need to know. COMET CCS, the Chinese trial from Lancet 2005. In that trial, the initiation of beta blockers on the first day of ACS, mainly STEMI, was associated with an increased risk of cardiogenic shock during that first day. The benefit from beta blockers on reinfarction and VFib emerging gradually beyond the second day. So beta blockers in that trial were hurtful the first day and gradually beneficial between day 2 to day 28. This trial was short-term beta blocker therapy for 28 days. So beta blockers significantly reduce the endpoint of death MI cardiac arrest between day 2 and day 28, but worsen this endpoint in the first day and in high-risk patients, particularly death, making the overall beta blocker effect neutral acutely. There was actually no benefit of starting the first day, even if you did not have high-risk features predictive of cardiogenic shock. The benefit occurs later, even in lower-risk patients. Therefore, beta blockers should be avoided on the first day of MI, particularly if there is any feature predictive of cardiogenic shock, as per that trial. Any heart failure, meaning KILIP class 2 to 4, systolic blood pressure less than 120 millimeter of mercury, heart rate over 110, or age over 70. So in this acute setting, you avoid beta blocker for a cutoff blood pressure of 120 and a heart rate of 110. We're more lenient on the second day and beyond. We can apply them for patients who absolutely need them, especially those with LV dysfunction, for a blood pressure up to 90. But not that first day. Your first day, you must be very careful with beta blockers. So the bottom line is start beta blockers slowly on the second day of MI in the absence of heart failure. May consider it the first day if you don't have any of those high-risk features, even though there is no clear benefit the first day, but at least there is no harm if you don't have those high-risk features. So start the second day, may consider the first day if no high-risk features. And on the second day, you may accept lower blood pressure, like I said, a cutoff of 90 to 100, and you may accept a higher heart rate than on the first day, but you don't accept at any time congestion and decompensated failure when you start beta blocker therapy. Now, intravenous beta blockers are preferably avoided in all patients, as this was the formulation used in the COMET CCS trial on the first day, but may rarely be used in a patient with ongoing ischemia plus none of those 4, except possibly high heart rate from AFib, not sinus tachycardia. So occasionally you may use IV beta blocker, try to avoid it, but occasionally a patient with active ischemia and none of the prior features, you may use it, especially if ischemia is driven by AFib. Now, I will move to the next idea, long-term beta blocker post-MI with low EF. So we discussed, try to avoid them the first day, especially if high-risk features. How about, are they beneficial long-term beyond those first 28 days? So this is the landmark trial, Capricorn trial. Carvedilol in post-MI patient with EF less than 40% and mean EF was 33%. Some of them had heart failure, some of them didn't. But in those patients, it improved long-term mortality. Carvedilol in that trial must be titrated to high doses, but start slowly and up-titrate slowly. In Capricorn, they started carvedilol on day 3 in non-congested patients, and they started at 6.25 VID and doubled it every 3 to 10 days. Remember that regimen. You can use that in a MI patient. So you can titrate a little faster than in the heart failure reduced EF population, but not too fast. It may be started day 2, as suggested by the COMET CCS trial, as long as no clinical heart failure or as long as clinical heart failure has been properly diuresed. Important idea, patients with heart failure are the most harmed by acute beta blocker therapy, but they are also the most helped by beta blocker long term. So those are the ones where you should not try the first day, but you should be very insistent on starting beta blocker second or third day, and not just that, up titrating to high doses gradually, partly inpatient, partly outpatient. Now, how about long-term beta blockade post-MI with normal EF over 50%? Data from the 80s addressing beta blockers in acute MI has shown that beta blockers reduce mortality after MI, whether heart failure is present or not. Beta blockers were really the earliest therapy for acute MI, before lytics, before aspirin. And in that era, they were helpful. However, in the reperfusion era and in patients who have been reperfused, if EF is normal, beta blocker therapy was not beneficial beyond 30 days in registries, whether REACH or FAST-MI registry. And we come to the trial, REDUCE-MI trial, published a few days ago and presented at ACC, which randomized MI patient with EF over 50%, 35% of whom were STEMI, the rest were non-STEMI. And those MI patients were managed invasively and revascularized, mostly by PCI. And they showed that long-term beta blocker therapy started at day 1 to 7 and up-titrated to fairly good doses, 100 milligram of metoprolol or 5 milligram of bisoprolol. It showed that long-term beta blocker therapy had absolutely no benefit on death or MI at 3.5 years follow-up. One of the reasons for that is that those revascularized patients with preserved EF have a low event rate in general. It was about only 2.5% per year with absolutely no benefit from beta blocker therapy. So no long-term benefit of beta blocker in post-MI setting with normal EF. So here's the bottom line. How do I put everything together between acute, long-term, low EF, long-term, normal EF? So combining the data from COMET, Capricorn, and REDUCE-MI, beta blocker post-MI is only beneficial in low EF patients, even more so low EF with heart failure, who nonetheless are harmed acutely by beta blocker the first day. Start beta blocker in those low EF patients at day 2 or beyond, once properly stabilize and diurese, and titrate slowly to high dose, but definitely try to titrate. Beta blocker may be considered in low-risk patient with normal EF for 1 month, as it was used in COMET CCS trial, and there was a benefit in 1 month as long as you're careful about initiation of those. There was a benefit between day 2 and 28 of beta blocker therapy in those lower risk patients. And there was some benefit in some registry up to 30 days. If used in those patients, low doses are probably enough as per Obtain registry published in JACC. So beta blocker also should be considered in the current era in non-revascularized patients or those with late reperfusion, like STEMI with late reperfusion. I want to move on to ACE inhibitor, early and long term. You need to know the two landmark trials from the 90s, ISIS-4 and GC3 trials. In those two landmark trials of ACE inhibitor in acute MI, ACE inhibitor was initiated in the first 24 hours in all types of MI, whether anterior or inferior, accompanied by heart failure or not, and was used also short-term for 6 weeks. ACE inhibitor improved that early mortality, and actually in those two trials, the survival curves started to diverge at day 1. You started to save lives at day 1 with ACE inhibitor. And the benefit became significant at 1 week and at 6 weeks. So, unlike beta blocker, actually, ACE inhibitor is beneficial from day 1, and you should try to start at day 1. ACE inhibitor, like beta blocker, is particularly beneficial in LV dysfunction, anterior MI, or heart failure, as has been proven by the SAVE trial, another trial from the 90s, that has shown a long-term benefit of ACE inhibitor in patients with that, LV dysfunction, anterior MI, or heart failure. So I mentioned ACE inhibitor was very beneficial to be started day 1 in those early trials. However, it should be avoided acutely if blood pressure less than 100, and there was more cardiogenic shock in those patients with blood pressure less than 100 if you start ACE inhibitor on day 1 in ISIS-4. So in those patients, wait before starting ACE inhibitor. Also, you start slow. These are some of the doses used in those trials. You start lisinopril 2.5 to 5 or captopril 6.25 BID, and you up-titrate over the course of 2 days to lisinopril 10 or captopril 50 milligram BID or 25 TID. The benefit is less marked when ACE inhibitor is used unselectively in all MI patients. Again, the SAVE trial showed more benefit in LV dysfunction, anterior MI, or heart failure, but the other two suggested a benefit in all patients. So the benefit is less marked in unselected all MI patient. However, there is a benefit, including in those with inferior MI and without heart failure, for a duration of 6 weeks as an ISIS and GC trial. So you should try to use them in all MI for at least 6 weeks to reduce the negative LV remodeling and early mortality. Beyond those 6 weeks, the benefit is less marked and questionable in the absence of LV dysfunction. You would still use them as first-line therapy for hypertension if the patient has hypertension, but it's less marked in the absence of low EF, heart failure, or anterior MI beyond 6 weeks. I will move on to aldosterone antagonists. You need to know those two major trials. So aldosterone antagonists started early in the hospital and given for years. It started day 3 to mostly day 7 in the hospital and given for years, improved both short-term, around 30 days, and long-term mortality and sudden death in post-acute MI patients with EF less than 40% associated with any degree of clinical heart failure. It's that combination, low EF with any degree of clinical heart failure or congestion at any time post-MI, or diabetes, even if you didn't have heart failure. This is the Ephesus trial, which has embraced as class 1 in MI guidelines. And you can see the survival curves split early. You start aldosterone antagonist in the hospital and you start getting early mortality benefit, which keeps growing wider with time. However, should we initiate aldosterone antagonists on the first day, like I discussed with ACE inhibitor and like I discussed with beta blocker, where no clear benefit the first day? So should we start at the first day? And should we give it in patients with normal EF? And this has been addressed in another trial, Albatross trial. The acute initiation of aldosterone antagonist in the emergency department in MI patient with the F over 40%, and they use here an IV formulation to start aldosterone antagonists in that trial. So the acute initiation in the emergency department in MI with the F more than 40% and mostly no clinical heart failure was not beneficial. So there are two conclusions from this trial. No benefit if normally F, especially with no heart failure, normally F with no heart failure, and possibly also no benefit of immediately starting aldosterone antagonist the first day versus more delayed start a couple of days later. You may wait a couple of days, unlike ACE inhibitor. Of note, in that trial, there was a small subgroup of STEMI, and the STEMI seemed to derive a mortality benefit, but not non-STEMI, which kind of fits with this idea. Probably the more LV dysfunction you have, the more likely you are to benefit from aldosterone antagonist a couple of days after admission. Another idea that gets asked is, how about Entresto and how about SGLT2 inhibitor post-MI started acutely? So those have been studied. Entresto, sacubitril, valsartan, started at day 1 to 7 post-MI and used long-term, did not reduce early or long-term mortality or heart failure in comparison to ACE inhibitor in acute MI patient with EF less than 40% or clinical congestion. So they took patients with low EF in an MI setting or clinical heart failure, and they randomized them to Entresto versus ACE inhibitor, and there was no benefit of Entresto on those patients, whether mortality or heart failure reduction. Those patients' EF was 36 plus or minus 9% on average. They were mostly STEMI, 76%, and 54% had heart failure. Why didn't Entresto help? Probably this population is lower risk than the chronic decompensated heart failure with reduced ejection fraction. Also, you get more hypotension with Entresto. That's a constant in all Entresto trial. And probably the acute MI patient who are less used to low blood pressure are less likely to tolerate a low blood pressure than the chronic heart failure population. Now, SGLT2 inhibitors have been studied in the acute MI setting, two major trials. And they have been studied, and compared to placebo, they were started at day 1 to 14 in the MI setting. And they did not reduce mortality in post-acute MI patient with EF less than 45% or clinical congestion. You have two trials, DAPT presented recently last year, and IMPACT-AMI presented a few days ago at ACC. In IMPACT-AMI and DAPT trial, the mean EF was 35 to 45%. 75% of patients were STEMI, and 57% had clinical congestion. So in DAPA, there was no improvement of any cardiac outcome. In IMPACT-MI, empagliflozin did not affect mortality at all, but it reduced post-MI heart failure hospitalization. However, the event rate was not high. It was 2.6 versus 3.6% heart failure hospitalization per year. The reason those did not work in the post-MI setting, again, the acute MI population is a lower risk than the chronic heart failure population, particularly the admitted decompensated chronic heart failure with reduced EF. So that's probably why SGLT2 inhibitor could not show benefit. And you can see the death rate in this population is 3.6% per year, which is lower than the death rate of the chronic heart failure with reduced EF, especially those who get admitted to the hospital. But because they reduced the heart failure hospitalization, empagliflozin reduced that, that doesn't mean it should be used in the post-MI setting. The reduction was not dramatic, but it means that, well, maybe if you identify a post-MI patient with a higher risk of heart failure admission in the future, especially that patients who has been dragging the hospital with heart failure post-MI, that's a patient who will likely benefit from long-term and short-term SGLT2 inhibitor in the post-MI setting. But don't use it on everybody regardless, even if their EF is low and even if they develop some heart failure at some point post-MI. So here is a summary slide of post-MI patient, what they should receive on discharge. Evidently aspirin, P2Y12 antagonist, and statin. Beta blocker, if low EF, started at day 2 or beyond after proper diuresis. It is important to attain high doses in this setting. Now, beta blocker may be considered, and I do consider it, strongly consider it actually myself, for 1 month in normal EF, but I'm not insistent on having higher doses in those patients, and I may stop it at their follow-up visit, particularly if the patient tells me he's feeling a little tired. And I would more strongly consider it even if the F is over 40% or 50% if the patient is not revascularized. Now, regarding ACE inhibitor ARB, I would try to use it on admission and use it for 6 weeks or longer. The therapy should be longer and more valuable if low EF or anterior MI. In the absence of low EF or anterior MI, I'm not insistent on long-term therapy. But again, I may use it first-line therapy for hypertension or CKD. Regarding spironolactone, I would use it if EF less than 40%, along with any degree of heart failure or diabetes. And contrary to decompensated heart failure with reduced EF, there is no clear value of routine, Entresto, or SGLT2 inhibitor post-MI, even if low EF or some degree of heart failure has developed. I received a question regarding ARB versus ACE inhibitor in acute MI. There are 2 trials that compared ARB versus ACE in acute MI, Valiant trial and Optimal trial. In both of those, ARB were shown to be equivalent to ACE inhibitors. In Optimal trial specifically, ARB had slightly more death than ACE inhibitor numerically, but that was not statistically significant. So overall, you may use ARB as an alternative to ACE inhibitor in acute MI. Another question regarding the subtleties of ACE inhibitor initiation the first day. With ACE inhibitor, you try to start them the first day, but you avoid them with the traditional contraindication. So avoid if the blood pressure is less than 100 acutely, although beyond the acute phase, beyond the day 1, like day 2, day 3, you may start them for a lower blood pressure cutoff, such as 90 or even 85 slowly. You also started slower in those patients with lower blood pressure, and you start lower dose and you up titrate slower. Another idea is, yes, you would avoid it in the case of acute kidney injury acutely, and you await until their kidney function stabilizes. All right, I want to move on to antiplatelet therapy. This is the platelet, and we have the ADP P2Y12 receptor, which is responsible for the activation of the 2B3A receptor, which is the final common pathway of platelet aggregation. So drugs that block this receptor eventually block the 2B3A receptor activation and the platelet aggregation. We have 3 oral agents that block that P2Y12 receptor, or 1 IV agent that blocks it, and we have IV agent to block the 2B3A receptors. And those are the most potent one, the blocker of the 2B3A receptor. Now, the oral agent blocking this receptor are Clopidogrel and prasugrel. Both of them give actually the same metabolite, which comes and blocks that receptor. Then you have ticagrelor, and you have cangrelor IV. This slide gives a summary of the comparison between Clopidogrel and prasugrel and ticagrelor. Prasugrel and ticagrelor, we call them the more potent P2Y12 inhibitors. So Clopidogrel inhibits about 35 to 40% of platelet aggregation. You need to know that number. Whereas prasugrel and ticagrelor inhibit 75% of platelet aggregation. Also, clopidogrel, that number is inconsistent. There is inter-individual variability depending on genetics, whereas with prasugrel and ticagrelor, it's a more consistent inhibition with very little to no resistance to those drugs. So that's one advantage of those drugs, more potent and more consistent inhibition of platelet aggregation. Onset of action, you need to know that with clopidogrel, even 600 load, it takes 2 to 6 hours for onset of effect, whereas with the other ones, with the proper load, it's half an hour to 2 hours. Another important idea to know is that clopidogrel is studied in all settings, stable CAD or MI, whereas prasugrel and ticagrelor are mainly beneficial in the MI setting, undergoing PCI mainly. And in that setting, they have been shown in landmark, although now old trial, they have been shown to reduce combined death MI stroke in comparison to clopidogrel by 2% at 1 year, although they increase also bleeding, major bleeding risk by about 0.6% at 1 year. So 1 year of therapy with those drugs compared to clopidogrel, it reduces combined ischemic endpoint by 2% at 1 year, increases bleeding by about 0.6% at 1 year. They are contraindicated in the higher bleeding risk population, specifically with prasugrel. They should be absolutely contraindicated in patients with any prior stroke or TIA, and they are relatively contraindicated in patients with small weight and older age. Those are also subgroups where you should be careful with ticagrelor, even though it's not absolutely contraindicated. Another note about ticagrelor is a reversible ADP receptor antagonist, but that doesn't mean it's a slow offset because it's a reversible binder to that ADP receptor, but it has a long half-life of about 15 hours. So it does linger around even after you stop it for about 3 to 4 days. Another idea about ticagrelor, it has some other ancillary effects. It has direct vasodilatory effect. It also has adenosine effects. It blocks the adenosine reuptake by red blood cells, so it has an adenosine vasodilator effect and possibly bronchospastic effect and dyspnea effect because of this adenosine effect. The first question I would address regarding those ADP receptor antagonists in general, whether clopidogrel or the rest, in a non-STEMI patient, should you preload the patient before he undergoes cath or should you not? I described in my prior talk that we do early invasive strategy in type 1 MI patient. Early invasive mean cath at 24 hours, and it's acceptable to do it at 24 to 72 hours. So in that waiting time, should we start ADP receptor antagonist? Well, there are 4 trials today that have evaluated that, and they have shown that there is no benefit of preloading. In fact, there was no benefit of preloading, and there was a higher bleeding risk of preloading those patients, particularly in those 2, a COST trial and the SCAR Swedish registry. There was no benefit, especially if cath is done within 24 hours of presentation, and especially if you're eventually using a potent and fast ADP receptor antagonist. So you can see here, most of those studies use the potent ADP receptor antagonist, although the SCAR Swedish registry used clopidogrel in half the patient. And in the SCAR registry, the time to cath was 1.9 days. So it wasn't mostly within the first 24 hours. Also in dubious trial, the time to cath median was close to 24 hours. So we had a lot of patients beyond 24 hours. One disadvantage and one explanation why bleeding risk will rise. One, of course, when you preload them before cath, about 15 to 20% will undergo CABG, and you potentially will increase the bleeding risk in those patients who will need CABG, or you'll make them wait for a while before CABG. That's one. Another thing is that about 25% don't undergo revascularization in non-STEMI. Some patients don't have CAD on cath, and those are patients who could potentially be harmed by that unnecessary preload. So the ESC guidelines recommend against upstream ADP receptor antagonists. And based on those trials, only aspirin and an anticoagulant appear sufficient before a timely PCI. And these are the 2023 ESC guidelines. Routine treatment with a P2Y12 receptor inhibitor in non-ST ACS in whom coronary anatomy is not known and early invasive management is planned is not recommended. Pre-treatment may be considered in STEMI, although I'm not discussing STEMI, but it may be considered in patient undergoing primary PCI strategy as long as you're certain the patient has a STEMI, not those questionable EKGs, partly because when it's a definite STEMI, it's almost certainly that they will undergo PCI and that they will need long-term antiplatelet P2Y12 antagonist therapy. Now, in non-STEMI, like I said, you avoid preload, but you may consider it with a low recommendation, class 2B, in patients with non-STEMI who are not expected to undergo cath in less than 24 hours and who have a low bleeding risk. But again, even in that setting, it's a low recommendation. It's best to load them in the cath lab once you decide PCI is decided on the table while you're preparing to do your PCI. Load with 600 of Clopidogrel or 180 of ticagrelor or 60 milligram of prasugrel. Now, the second question, those old landmark trials have shown a benefit of those ticagrelor and prasugrel over Clopidogrel for 1 year. So should we give those advanced P2Y12 antagonists to all ACS patients undergoing PCI as opposed to Clopidogrel? The answer is yes, per those data and per guidelines, but there are a lot of caveats. And this is the answer in the guidelines. They want you to use Clopidogrel only when prasugrel or ticagrelor are not available, cannot be tolerated, or are contraindicated. So they want you to use prasugrel or ticagrelor in ACS patients, STEMI or non-STEMI. They tell you to consider Clopidogrel for patients who are otherwise at high bleeding risk and in older patients older than 70. And this is from the ACC guidelines here. In patients with ACS undergoing PCI, it's reasonable to use ticagrelor or prasugrel in preference to Clopidogrel, and they give that a class 2A. So both guidelines want you to use the other ones instead of Clopidogrel in ACS patients. Not just prasugrel or ticagrelor, there is actually preference for prasugrel based on the ESC guidelines, class 2A preference to prasugrel over ticagrelor for patients undergoing PCI. This is based on that study, ESA-REACT 5, which you also need to know, which was published in New England Journal of Medicine 2019, and which took non-STEMI and STEMI patients. And it compared upstream ticagrelor before cath versus prasugrel during cath. So it was kind of a double assessment of upstream versus downstream therapy and ticagrelor versus prasugrel. And it showed, you can see here, prasugrel was superior to ticagrelor on MI death, mainly MI at 1 year, 9.3 versus 6.9% at 1 year. In a way, this study also showed that only downstream ADP receptor antagonist therapy is needed. So because of that trial, ESC guidelines give a class 2A preference for prasugrel instead of ticagrelor. But both are acceptable and both are preferred to Clopidogrel in those ESC and in the ACC guidelines. But like I said, there are caveats. One is that those trials are old, before current generation DS, before the widespread use of IVUS, both of which reduce the risk of stent thrombosis. And in those trials, the old trials, there was less stent thrombosis with those advanced therapy compared to Clopidogrel. But I would bet that in the current area, that reduction in stent thrombosis is a lot less. So that's one caveat. They are old, before the current era. Another caveat is that on sub-studies of prasugrel, it's been shown that prasugrel is really mainly beneficial in the higher risk subgroups, such as STEMI, diabetes, patients with recurrent events, and recurrent multiple or complex procedures. So prasugrel or ticagrelor, based on my reviewing the data, should be particularly considered in the high ischemic risk, low bleeding risk combination. And this is where they showed more benefit based on that Triton prasugrel subgroup analysis. And if you look with ticagrelor, there are two major studies that have shown that the lack of benefit in certain subgroup, particularly the elderly. This is the popular age trial published in Lancet 2020. They took non-STACS patient age more than 70. Clopidogrel versus ticagrelor. Clopidogrel led to lower bleeding, but same MACE and mortality compared to ticagrelor. So it was better in patients over the age of 70. Sweetheart registry, ticagrelor led to more mortality and bleeding versus clopidogrel in patients older than 80, but less mortality in patients younger than 80. So the bottom line of those, as in the Triton subgroup analysis, is avoid those beyond a certain age, avoid those in patients perceived at high bleeding risk, and probably reserve them for the highest ischemic risk patients, even though guidelines suggest applying them to everybody. There are other issues with ticagrelor to consider. It's a common issue. Besides bleeding, you get dyspnea in 20% of patients with ticagrelor, severe enough to warrant discontinuation in 10%. Those are big numbers. And this is partly explained by the adenosine effect that I mentioned. And maybe it's a direct neuronal effect. So I discussed the limitation and why in a lot of patients you may just start clopidogrel, particularly in the current era, particularly that combination of older age or higher bleeding risk, lower ischemic risk. None of those, for example, that's a lower ischemic risk. Now, how about de-escalation at 1 month? Let's say we started with aspirin and ticagrelor or prasugrel. Well, how about give it for 1 month and de-escalate? That's also something that's been suggested by the landmark Triton trial. Most of the benefit from prasugrel in that trial was in that first month. So how about de-escalating beyond the first month? And there are two major trials that suggested, yes, it's totally fine to de-escalate at 1 month to clopidogrel, even without doing genetic or platelet testing. Topic trial and Talos AMI trial. Patients who have been free of events for the first month after an ACS and who are receiving a potent P2Y12 inhibitor, you can de-escalate to aspirin plus clopidogrel at 1 month without a rise in ischemic event and actually with a significant dramatic reduction of bleeding events at 1 year. Same in the Talos AMI. So you should consider de-escalating at 1 month in those patients who are free of events at 1 month. The guidelines give it a class 2B for the de-escalation at 1 month, from a potent P2Y12 inhibitor to a less potent one. Now, here is the more difficult question. Now, in patient who's actually taking DAPT with clopidogrel, he's taking aspirin and clopidogrel. How about de-escalating to single clopidogrel therapy at 1 to 3 months? There are a lot of trials that have been assessing that. So you're not just de-escalating from aspirin plus ticagrelor to aspirin plus Plavix at 3 months or 1 month. Here, we're asking the question, can I de-escalate from aspirin plus Plavix to Plavix only at 1 to 3 months? And surprisingly, there are multiple trials that have shown that this can be done. These are some of the trials. So they de-escalated after 1 to 3 months of DAPT to mostly clopidogrel monotherapy. And they showed that it's safe to stop aspirin at 1 to 3 months. Master DAPT trial, which de-escalated to clopidogrel only at 1 month, and Master DAPT MI subgroup, de-escalated at 1 month. This had 38% MI. This one was purely MI. It was a subgroup of the MI patient. And both of them showed it's safe to de-escalate at 1 month. They selectively took patients at high bleeding risk. And they showed you have the same ischemic risk with de-escalation, yet a dramatic reduction of bleeding of about, in absolute value, 3% at 1 year. And it's about a third in relative term. Another trial, Smart Choice, showed the same. They de-escalated to Clopidogrel at 3 months, but only 26% were MI in that trial. However, don't be quick to stop aspirin at 1 to 3 months. There is another trial called Stop DAPT2 ACS trial, which was a Japanese trial published in JAMA, which only recruited ACS patients, 57% of whom were STEMI. And it did not focus on high bleeding risk, unlike Master DAPT. So Master DAPT took all comer, not just MI, and focused on high bleeding risk, although there is an MI subgroup analysis. But in Stop DAPT2, they only took ACS, and they did not focus on high bleeding risk patient. And they showed that actually DAPT of 1 month followed by Clopidogrel monotherapy led to more ischemic events at 1 year. More MI and target lesion revascularization, about 1% more at 1 year. Not dramatic, but that's considered significant by our standard, 1% more. So the bottom line of those is that 12 months of DAPT is still the preferred strategy in ACS. But based on this data, particularly the Master DAPT and the Smart Choice, both the ESC and the ACC guidelines allow, even in ACS, a shorter DAPT duration of 1 month only if you have high bleeding risk. It's given a class 2B recommendation in ESC and class 2A actually recommendation in the ACC. And they both allow stopping aspirin and doing Clopidogrel monotherapy at 3 months if non-high bleeding risk, but also non-high ischemic risk. So high bleeding risk, you can stop at 1 month. Non-high bleeding risk, but also non-high ischemic risk, you can stop at 3 months. And these are the guidelines. In high bleeding risk patient, aspirin or P2Y12 inhibitor monotherapy after 1 month of DAPT may be considered, but it's mainly P2Y12 receptor inhibitor monotherapy. So they give it class 2B at 1 month. And in patients who are event-free after 3 to 6 months of DAPT and who are not at high ischemic risk, single antiplatelet therapy, preferably P2Y12 receptor, should be considered. They give that class 2A. And this is the ESC guidelines. So they allow you 1 month in high bleeding risk, 3 to 6 months in standard risk patients. And these are the ACC revascularization guidelines, 2021. Discontinuation of aspirin after 1 to 3 months with continued P2Y12 monotherapy, including Clopidogrel, in ACS patient. They give it a class 2A. So if you have to stop at 1 month, both guidelines allow you to stop it, whether because of active bleeding or because of perceived high bleeding risk, or if you need to interrupt for a major procedure. They also allow it more readily at 3 months, both ESC and ACC guidelines. The preferred strategy is still 12 months based on the Stop DAPT2 ACS trial. Now, I want to just tell you, what do we consider high ischemic risk, high bleeding risk? There are several classifications. You use your clinical judgment, but here is what we call high ischemic risk if you want to use an algorithm. One, the most important thing when we say high ischemic risk is what was the original indication and the setting for stenting. MI versus stable CAD. Your biggest predictor of future ischemic event is MI stenting versus stable CAD stenting. You have much higher risk of further ischemic event and stent event if your initial event was MI. Okay, so that's the single most important one in your further decision making. That's why you see, for example, in those guidelines, we always split when we decide about antiplatelet therapy, stable CAD versus ACS. So that's higher ischemic risk. But there are other clinical features beside MI presentation, such as diabetes, multiple prior MI event, multiple prior PCI, multi-vessel PCI, and polyvascular disease, such as patients with CAD and PAD. So those are other features you look at. Those are the clinical features. Then you have a group of technical features. So you look at clinical features, mainly MI presentation versus stable CAD, along with other ones such as diabetes, uncontrolled risk factors, multivessel disease, PAD. And you look at technical aspect. And here you have the 3 stents, 3 lesions, 3 vessels, total stent length over 60 millimeter, bifurcation or CTO or left main. Those are technical features that are associated with higher future events. So you decide if the patient has high ischemic risk based on that combo. If you have both clinical features, MI presentation and diabetes, and technical feature, this is a high ischemic risk patient. You really want to try to avoid stopping antiplatelet before a year. If you have none of those, or you have MI presentation but no other clinical or complex technical features, well, that may be an MI patient. You feel comfortable stopping aspirin at 1 month on. So the combination of both give you high thrombotic risk. Now, what do we call high bleeding risk? You can use the score that was used in the master DAPT trial. And what they called high bleeding risk is they use something called a precise DAPT score. You can use that. But the general ideas are age over 70, 75, baseline anemia, hemoglobin less than 11, prior bleed or transfusion, cancer, any active cancer or recently active cancer, prior stroke or TIA, that's inherently high bleeding risk, requiring anticoagulation or NSAID or steroid, that's a high bleeding risk. Okay, so any of those features puts you in a high bleeding risk category. Age, prior bleed, anemia, cancer, stroke. Don't forget, stroke is a high bleeding risk patient. Okay. Another idea I want to discuss in terms of antiplatelet, it gets more complicated because you have a lot of options. So, okay, let's say we started the more advanced antiplatelet with ticagrelor. I told you, if you start ticagrelor, consider de-escalating to DAPT with Clopidogrel at 1 month. And I mentioned the data for that. But interestingly, a lot of modern trials that you need to know of suggest that, well, if you want to keep ticagrelor with its potential anti-ischemic benefit compared to Clopidogrel, well, maybe a creative strategy here is rather than de-escalating to DAPT with Clopidogrel, well, maybe de-escalate to single ticagrelor, just to stop the aspirin and keep ticagrelor. Maybe that's a better strategy than de-escalating to DAPT with Clopidogrel. And there are 3 trials. They did not compare ticagrelor monotherapy versus DAPT with Clopidogrel, but they did compare ticagrelor monotherapy versus ticagrelor plus aspirin beyond 1 month. And they showed that actually at 1 month or 3 months, you may stop aspirin without any harm and actually with a dramatic bleeding benefit. You cut the bleeding risk in half and by about 2+% in absolute value at 1 year. One of those trials is the ultimate DAPT trial of ACS patient presented at ACC a few days ago. Ticagrelor monotherapy at 1 month was superior to DAPT with ticagrelor continued at 1 year. So you should strongly consider stopping aspirin. If you don't feel comfortable downgrading from DAPT ticagrelor to DAPT Clopidogrel, well, at least downgrade from DAPT ticagrelor to ticagrelor monotherapy. There are other trials suggesting the same thing. TICO of ACS patients and Twilight trial of high-risk CAD or ACS patients. They downgraded to ticagrelor monotherapy safely at 3 months. So consider ticagrelor monotherapy at 1 to 3 months. I will mention a quick idea regarding patients who need chronic anticoagulation. quickly. So those who have a fib or recent DVT-PE, the default strategy in those patients is triple therapy, aspirin, clopidogrel, and anticoagulant, peri-PCI for up to 1 week, then dual therapy immediately on discharge or beyond 1 week. You give oral anticoagulant plus clopidogrel on discharge or beyond 1 week. So no aspirin except during hospitalization up to 1 week. If you have high ischemic risk and low bleeding risk, you may consider triple therapy for 1 month. Oral anticoagulant plus clopidogrel plus aspirin, then double therapy beyond 1 month. This data is based on 5 major trials, but the Augustus trial with apixaban is the one that suggested that there may be benefit of triple therapy for 1 month in those combination of high ischemic risk, low bleeding risk, as I explained what is high ischemic and low bleeding risk. In all cases, at 12 months, stop clopidogrel and continue anticoagulant only, single therapy. This is based on FIRE trial and some other registries. A lot of doctors don't do that. At 1 year, you do not need double therapy. You do not need antiplatelet in most of those patients. You can stop the anticoagulant. You may keep double therapy in patients perceived at very high ischemic risk, but the standard is to stop antiplatelet at 1 year and stick with the anticoagulant in those patients requiring chronic anticoagulation. Clopidogrel is the preferred ADP receptor antagonist in combination with anticoagulation. Rarely ticagrelor was used in those landmark trials, but avoid prasugrel. All right, I want to talk about anticoagulation now. So this is the coagulation cascade. We have 4 parenteral anticoagulants that we use acutely in ACS. Mainly we use low molecular weight heparin and unfractionated heparin, which inhibit antithrombin 3, which eventually inhibit the activity of factor 10A and thrombin. Unfractionated heparin inhibit preferentially the thrombin, whereas low molecular weight heparin inhibits more 10A than thrombin, with a ratio of 4:1 inhibition of 10A versus thrombin. You have fondaparinux given subcutaneously, which inhibits exclusively 10A, and you have bivalirudin IV, which inhibits the thrombin. And you have the oral anticoagulant that you can see here, which are not specifically used for ACS, as you know, but those inhibit 10A, whereas dabigatran inhibit thrombin. So what anticoagulant do we use in ACS? Heparin is used before PCI and during PCI and is the preferred agent based on guidelines. Specifically, SC guideline is given in class 1. The target PTT is 1.5 to 2 times, which is about 50 to 70 seconds. Enoxaparin is less favored, especially if you undergo cath in the first 24 hours. Why? Because in invasively managed non-STEMI, enoxaparin causes more bleeding than unfractionated heparin based on the Synergy trial and based on the invasive arm of A to Z trial. Those are landmark enoxaparin trials versus heparin. And this is particularly the case if you get crossover between enoxaparin and heparin. Those are the patients who get the most massive bleeding risk. If you give enoxaparin, then you cath and give heparin during cath, those are the patients who get the most bleeding risk. And that's why enoxaparin is less favored in ACS, especially if cath is done in the first 24 hours. Now, if you use enoxaparin in ACS, again, less favored. But if you do use it, how do you do cath and PCI with enoxaparin? A few doctors in the US know that, but you really need to know that if you're using enoxaparin at your institution. So here is how it goes. If you've used 2 doses of subcutaneous enoxaparin, so 1 milligram per kilogram sub-Q, Q12 hours, and you've already used 2 doses, you can do your PCI without any additional anticoagulation during your PCI. Normally, when you do PCI, we give unfractionated heparin and we track the ACT. If the patient has gotten 2 subcutaneous doses of enoxaparin already, and the last dose is within the last 8 hours, you do not need to give any anticoagulation or track any ACT during your PCI. However, when PCI is performed within a few hours of presentation and only a single subcu dose of enoxaparin has been given, so enoxaparin effect has not reached steady state, that enoxaparin is not going to provide appropriate anticoagulation for PCI, and you will need to give IV enoxaparin, 0.3 milligram per kilogram during PCI, or less favorably, you will need to give unfractionated heparin, but then you run the risk of significant and dramatic increase in bleeding risk. A lot of labs don't carry intravenous enoxaparin in the US, and that's why that enoxaparin in the US is probably not a great strategy at institutions that don't carry intravenous enoxaparin and that are cathing in the first 24 hours. Also, even if you've gotten 2 doses of enoxaparin, if you're doing your PCI 8 to 12 hours after the last subcu dose, the enoxaparin anticoagulant effect is waning here. And therefore, you need to give also that 0.3 milligram per kilogram IV enoxaparin during PCI. So the bottom line is too complicated to use when cath is done within 24 hours of presentation, which is the most common scenario these days, cath within 24 hours. And that's one reason why enoxaparin is less favored in the ESC guidelines. And I'll argue it should be less favored in the US, where it's less widely available in the cath lab. So these are the ESC guidelines. So for patient undergoing cath in less than 24 hours, it's unfractionated heparin that you should use. Enoxaparin is given a class 2A. It's less favored. So issues with enoxaparin, I mentioned higher TIMI major and gastro-severe bleeding risk than unfractionated heparin in invasively managed patient, while giving the same ischemic reduction. So why use it if it gives you more bleeding risk? And bleeding risk particularly high if you get crossover. Also, bleeding risk particularly high the more you get CKD, because bleeding increases more sharply with enoxaparin than unfractionated heparin. The more your GFR drops below 90, especially below 60, yet you're still giving the same dosing regimen until a GFR of 30. Enoxaparin is renally cleared, whereas heparin is cleared by the reticuloendothelial system. So it's not affected much by renal function, whereas enoxaparin is, and it's less predictable what will happen at GFRs between 30 and 90. Also, like I mentioned, difficult dosing of enoxaparin if less than 2 subcu doses have been given in the first 24 hours, or if the last dose is between 8 to 12 hours. Where does enoxaparin data come from in ACS? There are 2 old trials that you need to know, ESSENCE and TIMI-11B, that put enoxaparin on the map in ACS. Both have shown that in conservatively managed patients who do not get cath, patient managed conservatively, enoxaparin reduced ischemic endpoint compared to heparin, but again, it caused higher bleeding. But in invasively managed patient, we use those trials, Synergy and A to Z trial, and they showed no benefit absolutely of enoxaparin and only harm from increased bleeding risk. Now, what are the doses? For heparin, in the landmark heparin trial of ACS, which was published in 1988, which established that heparin is valuable in ACS, the PTT target was 1.5 to 2 times upper limit of normal. That's the same in Synergy and A to Z trial. PTT is 1.5 to 2 times upper limit normal, and this is how it was given up front. 60 units per kilogram bolus up to 4,000 units, then 12 units per kilogram per hour. Well, the idea I want to mention of that is compare that dose to the heparin dose in PE. In the landmark trials of PE, the heparin dosing that was used was 2 to 3 times upper limit of normal. That was the target. So the idea is that in ACS, your PTT target is lower than your PTT target in PE. Less anticoagulation is needed in ACS than in PE. Another idea, some doctors think that heparin can only be used for 48 hours, whereas enoxaparin can be used for up to 8 days. Actually, even in the medical therapy trials, Essence and TIMI-11B of medically treated non-STEMI, the trial therapy, whether heparin or enoxaparin, was given for 48 hours and up to a maximum of 8 days. So for both, for medically managed ACS patient, which is rare these days, the anticoagulant is administered for 48 hours and up to 8 days. That's the recommended duration. Another expansion on that idea of ACS versus PE degree of anticoagulation, a low dose sub-Q fondaparinux, which is 2.5 milligram daily, which is actually a DVT prophylaxis dose of sub-Q fondaparinux, has been compared to a therapeutic dose of enoxaparin, 1 milligram per kilogram twice daily in the landmark OASIS 5 trial. And it has been shown to be actually as effective on reducing MI ischemic events with a large reduction in major and fatal bleeding risk, which translated into mortality reduction. So a DVT dose of fondaparinux was better than full dose of enoxaparin with a mortality reduction in OASIS 5 trial. Again, the idea of that trial that I want to mention, I'm not telling you to use DVT prophylaxis dose. I don't suggest for this. And actually the ACS trial, they all use therapeutic dose of heparin or enoxaparin. But the idea I want to mention to you, it further corroborates that trial, that a moderate rather than high-level anticoagulation is appropriate for ischemic reduction in ACS, less than that required in pulmonary embolism, except during actual PCI, and that moderate anticoagulation level minimizes the dreaded bleeding risk. And along those lines, that fondaparinux 2.5 milligram QD is a good option for ACS patient undergoing cath beyond 24 hours. And if you're undergoing cath beyond 24 hours, you might use that fondaparinux instead of enoxaparin. It's given a class 1 recommendation in the ESC guideline. The problem is not widely available at US hospital, but if it is available at your hospital, use it, especially if cath is going to be more than 24 hours. But keep in mind, unlike enoxaparin, this doesn't provide any anticoagulation for PCI purposes. So you use it, and once you go for cath and you decide I'm going to do PCI, you give heparin, ignoring the fact that the patient received fondaparinux. You give heparin, and you dose heparin based on your ACT. During PCI in general, whether you've received heparin before cath or you've received fondaparinux, you give or add high-dose anticoagulation. The typical dose we give during PCI 70 to 100 units per kilogram of unfractionated heparin with a target ACT of 250 to 300 seconds if no GPI. Anticoagulation is stopped after PCI. We don't follow those 48 hours to 8 days. We stop it immediately after PCI. The only exception is if you're using bivalirudin, which nowadays is mainly used in HIT patients, then you can keep bivalirudin infusion high dose for 1 to 4 hours post-PCI to reduce acute stent thrombosis. Bivalirudin, if you stop it immediately after PCI, has been associated with an increased risk of acute stent thrombosis. So you keep that infusion 1 to 4 hours. But otherwise, with heparin, we stop immediately after PCI. I want to discuss one final idea that is extremely important that we face every day. Patients already receiving oral anticoagulation with warfarin or NOAC. What is the medical therapy before you cath them? So there are actually clear-cut European guidelines of how to handle those patients in the radial era. In the radial era, you do not need to hold the oral anticoagulant, whether warfarin or NOAC, before your cath, and therefore you do not need to switch to heparin before cath. What you do in those patients, you give IV unfractionated heparin during PCI on top of whatever they are on. So you cath them while they are actively taking warfarin or NOAC. And you do not add in parenteral anticoagulant before cath unless INR is less than 2 with warfarin, or unless the last NOAC dose was more than 12 to 24 hours. 12 hours with apixaban or 24 hours with rivaroxaban. Basically, unless you're at the nadir of that NOAC dose. So you do not add oral anticoagulant unless you are at the nadir of that NOAC dose. And how do you manage warfarin in transradial catheterization? Warfarin therapy is not interrupted. Again, that same idea here. It's a class 2A in the ESC2, not interrupted. You do cath, and if PCI is performed, unfractionated heparin is administered and adjusted according to ACT target of more than 250. And per ESC, unfractionated heparin is mainly required if your INR less than 2.5. They suggest not giving any heparin if your INR is more than 2.5, but I personally don't feel comfortable with that. I would give heparin and track ACT in patients who have been receiving warfarin, even if INR is over 2.5 personally. Now, NOAC management in transradial catheterization. NOAC may be continued around the transradial procedure without any interruption, class 2A in the ESC, and you give heparin on top of it during PCI. And if PCI is performed, you give 6 units per kilogram and monitor ACT regardless of the time of NOAC, even if he got his apixaban 4 hours ago or 2 hours ago. Personally, however, with NOAC, I prefer to hold one dose before cath, or basically to do my cath at the nadir of the prior dose. So let's say I like to do cath about 12 hours or so, 12 plus hours after apixaban, 24 hours after rivaroxaban, at the nadir dose, just to avoid excessive, uncontrolled anticoagulation during PCI. Particularly if you get a complication, it will be hard to control it, such as perforation. Now, if you're planning to do transfemoral procedure and you know ahead of time, this is a patient who needs complex PCI and I need to do either large sheath groin access or I need support device. And for those reasons, I need to do femoral access, or maybe it's a cabbage patient on whom you deemed I need to do femoral access. So those patients, you need to hold anticoagulation before cath. And the way you hold it, for NOAC, we hold the NOAC for 1 to 2 days. 1 day in the patient perceived at lower bleeding risk, and 2 days in patient perceived at higher bleeding risk. And you start unfractionated heparin at the nadir of last dose while waiting for cath. So at 12 to 24 hours, 12 hours with apixaban, 24 hours with rivaroxaban, you start unfractionated heparin. How about warfarin transfemoral cath? Then you hold warfarin and you bridge with unfractionated heparin when INR drops less than 2, and you cath when INR is equal or less than 1.6. And for NOAC, when do I do 1 to 2 days? It's a personal judgment. A lot of time I wait 36 hours. But the idea here, if I'm going to do large groin sheath or I'm going to use support device, then I definitely aim toward 2 days. If they have CKD, then I definitely aim toward 2 days. If they are high bleeding risk patient in general, anemic, cancer, PAD patients, I will aim more toward 2 days. And these are from the guidelines, the ESC guidelines, and here they tell you on patient on oral anticoagulant, PCI is performed without interruption of vitamin K antagonists or NOAC. In patient on NOAC, regardless of the timing of the last administration of NOAC, add low-dose parenteral anticoagulation. They give a class 2A to do your cath and PCI without interruption of warfarin or NOAC. The downside of not holding the oral anticoagulant before your radial procedure is that if you need to convert to a femoral procedure in that patient, if your radial access fails in a small percent of patients, up to 5%, in those patients, you may not be able to convert to a femoral access immediately. You have to send them back to the floor, hold the anticoagulant, potentially put them on heparin at the nadir of the NOAC, then bring them back 1 to 2 days later to do femoral access. Well, I want to discuss this one last thing, then I will stop. The IV antiplatelet, GPI and ticagrelor, glycoprotein inhibitor during PCI, it causes 95% inhibition of platelet aggregation. It is the most potent platelet antagonist. It's less used today. It's still used, though, in up to 15% of STEMI and 5 to 10% of non-STEMI in modern trials. It's only used today as bailout for no reflow or large thrombus burden. particularly in STEMI, or thrombotic complication during cath, including distal emboli, plus or minus flow-limiting dissection. And it's given a class 2A for those. Bleeding risk drastically increases with GPI in general, but particularly in patients older than 70, women, and CKD. Even in the trial from the years 2000s, benefit was not seen in those subgroups, and you should try to avoid it. Also, benefit was not seen even in the early landmark trials in patients undergoing a graft intervention. So you should try to avoid it in graft intervention, even if you have high thrombus burden in those patients. And remember to adjust your dose for CKD GFR less than 50. Instead of 2 boluses for eptifibatide, we give only 1 bolus, and we have the drip rate. So we give 1 or 2 boluses for eptifibatide, 1 bolus of CKD, and 1 bolus for tirofiban in all patients. Then we give an infusion for 12 to 18 hours. That's the standard. They have a relatively short half-life of 2 to 2.5 hours, and they are reversible to B3A receptor antagonists, which means that in that 2 to 2.5 hours, if you bleed, you can do platelet transfusion, but being reversible to B3A receptor antagonist, they hang around, they move around between platelet, and they may move and inhibit your transfused platelets. So platelet transfusion may not be efficacious in that 2 to 2.5 hours, but luckily, they have a short half-life. They don't hang around for too long. Regarding cangrelor, it's very different from a glycoprotein inhibitor. Cangrelor blocks the ADP receptor antagonist like prasugrel and ticagrelor, but it's very potent, 90% platelet inhibition, more potent than ticagrelor or prasugrel, but it's less potent than glycoprotein inhibitors. It is reversible like ticagrelor, but it has a very short half-life. So it's more like an on-off effect of cangrelor. It is useful during PCI in patients who have not been preloaded with ADP receptor antagonist, whether stable CAD or ACS, and it's given only class 2B recommendation in ESC guidelines and ACC guidelines. When do we use it? So we use it in patients who have not been preloaded with ADP receptor antagonist, who are naive to ADP receptor antagonists, and you give it at the start of PCI, for the whole duration of PCI, and at least 2 hours if your PCI is shorter than 2 hours. What it has been shown to do, it reduces your acute stent thrombosis and procedural complication, but no effect on mortality. So based on guidelines, ESC and ACC, it's given a class 2B recommendation in ADP antagonist naive patient, particularly if ADP antagonist naive and you're in a shock state where you cannot give oral agents or where the oral agents absorption is questionable, or you're undergoing high-risk PCI and you don't want to wait for the effect of clopidogrel or ticagrelor to kick in. Even ticagrelor, it takes up to 2 hours for the effect to kick in. Keep in mind, extremely importantly, unlike glycoprotein 2B3 inhibitor, cangrelor has no role in patient preloaded with oral ADP antagonist. Why? If you are already on ADP receptor antagonist, your ADP receptor is blocked by your oral agents. So cangrelor is not going to be able to bind extensively to those receptors. So it may not give you much more antiplatelet effect. So it's not a good bailout agent on top of oral ADP receptor antagonist. So for bailout cases, no reflow, high thrombus burden, a glycoprotein inhibitor is the one proven beneficial by data and recommended in ESC guidelines, not cangrelor. Do not equate the two. Cangrelor is only valuable if you're not on oral ADP receptor antagonist and you want a quick effect of ADP receptor antagonists, such as I mentioned, maybe high-risk PCI and shock state, and it's only class 2B recommendation. And you need to know how to switch. So I said you give cangrelor in those patients who aren't on ADP receptor antagonists. Well, you need to give them clopidogrel or prasugrel or ticagrelor eventually. Well, how do you do that? That's another problem with cangrelor. You cannot give clopidogrel or prasugrel while they are actively receiving cangrelor because the ADP receptor is occupied by cangrelor. And if you give clopidogrel or prasugrel, their metabolite, their active metabolite, is not going to be able to bind. And since that metabolite has a short half-life, by the time cangrelor is stopped, the metabolite is gone as well, and then you get no effect from clopidogrel or prasugrel. So you need to wait till the end of infusion to give a load of clopidogrel or prasugrel. And that's a problem because the load takes time to kick in. Even with prasugrel, it takes 2 hours, up to 2 hours to kick in. So that transition zone between cangrelor and clopidogrel prasugrel is risky because you have less antiplatelet effect in that transition zone. Ticagrelor is the only one that can be given during cangrelor infusion, partly because it has a long half-life, so it will hang around longer to bind to that receptor, P2Y12 receptor. Second, ticagrelor binds to a different part of the P2Y12 receptor. It doesn't bind to where the ADP bind and to where cangrelor bind. It binds to a different area. So it can still bind to the receptor while cangrelor is binding to it.